Welcome to Derm Drop, your TLDR in dermatology. I'm David Sider, bringing you quick picks from the literature and the dermatology news so that you can stay caught up on your commute. If you want the deep dive, head on over to my LinkedIn. That's David Seiter, Seiter, and there you will find links to the articles and other original content. In the meantime, let's start with my first question, which is why on earth would you treat inactive morphea? Well, that was my question that I had when I saw Eric Dean's post on X. Dr. Eric Dean is with the Institute of Rheumatic and Autoimmune Diseases at Overlook Medical Center, and he posted a handy Morphea treatment algorithm on X, and that was later reposted on LinkedIn by RheumNow, and it included an arm for inactive disease. So, in addition to succinctly outlining escalating approaches to circumscribed versus linear, generalized, and/or pansclerotic disease, Dr. Dean's flowchart powerfully highlighted the importance of holistic, patient-centered care that includes attention to the damage and other sequelae left behind after morphea becomes senescent. Depending on the location and extent of the disease, rehab, including physical therapy and occupational therapy, psychological support, and plastic surgery with or without fat transfer are modalities that may be required to regain functionality and dignity following debilitating or disfiguring morphea. So the take-home point I got from that algorithm, as handy as it was about active disease, was to not stop when the morphea stops. Here's a snapshot of that algorithm. It really gives you a good, quick overview of how to approach the various forms of morphea. So check that out. Again, you can find the algorithm and the original post link on my LinkedIn account. Moving on to the next quick pick, with the question being, what is the frequency of cutaneous T-cell lymphoma following JAK inhibition for atopic dermatitis? Well, it turns out to be 6 times less frequent than CTCL following exposure to dupilumab, according to the FDA's Adverse Event Reporting System, and Dr. Shamir Geller's skin lymphoma group, including Drs. Robert Stuver and Melissa Pulitzer at the Memorial Sloan Kettering Cancer Center, and their retrospective cohort study of IL-4/13 blockade preceding CTCL, which can be found in the February 1st, 2025 issue of the Journal of the American Academy of Dermatology. Previous publications on the role of dupilumab in the development of CTCL stirred significant controversy, with many dismissing the association due to the likelihood of misdiagnosing early cutaneous T-cell lymphoma as atopic dermatitis. Potential confounders are not hard to identify here, but the relative rarity of CTCL following JAK inhibitor use for atopic dermatitis supports the possibility of a pathomechanistic relationship between the mechanism of action and the evolution of CTCL, and it does deserve further investigation, whether that is to allay our fears or to instill further caution when prescribing this groundbreaking biologic for presumed eczema. So stay tuned, this story's not over yet. When you check the content on LinkedIn, you will see that Dr. Geller provided a pretty succinct click-through that includes additional publications on the topic. It's only about 6 slides long, so check that out. My next quick pick is on dual biologic therapy, and yes, it is a thing. Some of the toughest cases in dermatology are the recalcitrant psoriatic arthritis patients and the unlucky patients with concomitant atopic dermatitis and psoriasis, which of course is also a thing. We didn't used to think so in dermatology, but I found data to show that there is a pooled prevalence rate of 2% of patients with either disease having the other disease, according to a systematic review published in the June 2021 issue of Skin Health and Disease. So there are creative ways around access challenges. I've included separate diagnoses for psoriasis and psoriatic arthritis, collaboration with rheum or GI colleagues, and patient assistance programs when all else fails. And because there are ways around those access challenges, the safety concerns may be the primary source of hesitation among dermatology providers. So it might be surprising that the first reports of comparable safety between dual biologic therapy, or otherwise termed DBT, and monobiologic therapy date all the way back to 2007, which is, I don't know how many years in dog years, but quite a few in dermatology years. That was for Crohn's disease, and subsequent case reports, retrospective studies, and systematic reviews have shown increased efficacy of DBT with similar safety in inflammatory bowel disease patients. Notably, in the Vega study combining guselkumab, which of course is an IL-23 inhibitor, with golimumab, a TNF-alpha inhibitor, for ulcerative colitis, published in the April 2023 issue of the Lancet Gastroenterology and Hepatology, the patients receiving both medications had a lower rate, yes, you read that right, a lower rate of adverse events, which turned out to be 63%, than the patients in the monotherapy arms, which were 76% and 65% for golimumab and guselkumab, respectively, with higher response rates, which is nice, 83% versus 61% and 75% respectively. But of course, not as much data exists for dermatology patients. But in the October 2019 issue of the JAD case reports, there was a case report of a patient with psoriasis and psoriatic arthritis treated with various dual biologic therapies involving TNF alpha with IL-17 or IL-23 inhibition, ultimately achieving better control with fewer adverse events, in fact, none, on etanercept and guselkumab than she had on escalated dose monotherapy or biologic plus DMARD combination therapy. That report includes a summary table of 15 other case reports with currently available agents, some of which do include reports of infectious complications. So it's not a perfect track record with dual biologic therapy, but of course, we well know that monobiologic therapy does not have a perfect track record either. So what about psoriasis with atopic dermatitis? The hesitation here stems from the fear of paradoxical upregulation of one axis, for example, the Th2 axis, after inhibition of the other axis, which in this case would be Th17. However, a recent study reported paradoxical eczematous reactions on IL-23 inhibitors having an incidence rate of only 0.56 per 100,000 patient years. So that should be encouraging and reassuring. And in a research letter published in the July 2024 issue of the JAD, Mary Grace Hren, Sophie Gwenin, and Sakshi Khatri describe 12 patients with atopic dermatitis and concomitant psoriasis, psoriatic arthritis, or inflammatory bowel disease, prescribed dupilumab or tralokinumab with guselkumab, risankizumab, tildrakizumab, or ustekinumab with positive responses and only minor adverse events. And I'd like to give a shout out to Dr. Kevin Kia, who first talked to me about dual biologic therapy and inspired my deep dive into the topic. Hopefully, this will be something that changes your practice as much as it has mine. And if you're interested in the JAD case report, head on over to the LinkedIn account where I've got the article linked. Last for this particular episode is good news, something simple that will make your life and your patients' lives easier. And that's the recommendation that you do not have to order baseline or ongoing lab monitoring for your Deucravacitinib patients anymore, at least according to a large panel of experts who published their consensus findings in the February 2025 issue of the Journal of Drugs and Dermatology. These names, they're all stars in my book. They include, just to pick a few, Dr. Alexandra Golant, Dr. George Hahn, Sylvia Su, Ben Lakshin, Mark Lebwall, and Brad Glick, to name a few of the many. They recommended that laboratory monitoring is not required, but of course the Sotyktu package insert does indicate TB evaluation prior to initiating treatment and periodic evaluation of triglycerides as well as liver enzymes at baseline and thereafter, whatever that means, in patients with known or suspected liver disease. Elevated CPK levels are also referenced in association with reported cases of rhabdomyolysis without a recommendation to monitor. However, based on 14 articles and a modified Delphi process with unanimous approval, the group did not find evidence that Deucravacitinib caused lab abnormalities. And to be honest, given the FDA's history of inconsistency with JAK inhibitors, I trust that all-star panel more than I do the package insert. And I'm thinking about, for one example, the fact that ruxolitinib has a boxed warning on its topical form, but not on its oral form. Again, that review can be found, a link to that review can be found on my LinkedIn account at David Seiter, Seiter. Thanks again for tuning into this episode and look forward to more coming at you in the future.